And so you can see here that, again, American Indian and Alaska Natives experience the highest disparity, at least 3 to 4 times the rate of SMM as white non-Hispanics. But you can also see here that Black and African American, Asian Americans, and Hispanic or Latinos also experience higher rates of severe maternal morbidity than white non-Hispanics. So there are disparities in Arizona related to maternal health outcomes that we want to avoid and address. If you go to the next slide, Dave. So here, you can also see that there are disparities by maternal residence or where women live. So again, this is not maternal mortality. We're still looking at severe maternal morbidities. So there's really severe outcomes during labor and delivery. But rural Arizonans do experience a higher rate of severe maternal morbidity than women living in urban areas. And you can see in that map on the right-hand side that women who are in the northeastern portion of our state, so Apache County, Navajo County, Graham County as well, towards central Arizona, experience a higher rate of severe maternal morbidity. And this is kind of aligned with the maternity care deserts that Martine was talking about earlier. So again, we know that we want to be focusing on women in rural areas as well. So if you go to the next slide, Dave. So this is a little bit more granular. Now we're looking at primary care area. So not necessarily by county, but by primary care area. And you can see here the areas that are the darkest colors. I know it's really small on your screen, but it's mostly some of our Indigenous and Indigenous communities and reservations. So the Hopi tribe, San Carlos Apache, Gila River Indian community, Tohono O'odham. Some of those communities are experiencing the highest rates of severe maternal morbidity once we get to that more granular level. If you go to the next slide, we're going to zoom in here on, this is the Phoenix area. So again, you can see Salt River, Pima, Maricopa, Gila River Indian community, and then Gold Canyon have some of the highest rates of SMM. But you can also see that some of our central Phoenix locations like the Alhambra Village and Canto Village, Central City Village, also experience higher rates of SMM. So we go one more slide. This is the zoom in for the Tucson area. So Tohono O'odham again, and Tucson Estates having the highest rates of SMM in the Tucson area. And then you can see some of the central Tucson areas as well. So Tucson South, Casa Adobes, Flowing Wells, all with higher rates of SMM. So we'll go one more slide, sorry. So if we switch gears and start looking at the combined infant mortality by race and ethnicity, we see some similar patterns, but just slightly higher, or the highest, I guess, infant mortality rate among Black and African American infants, followed by white non-Hispanic infants, and then American Indian and Alaska Natives coming in at that third level. If we go to the next slide, Dave. And again, if we're looking at area of residence or county by where infants are dying in our state, you can see again, rural Arizonans experience the higher disparity in infant mortality. And with the map, you can see that some of the highest areas are Navajo County, La Paz, Gila, and Yavapai. So if you go to the next slide, at this time, that's the sort of the intro data for you. At this time, if you'll give us just a second to sort of switch gears here, I want to introduce Dr. Thompson first. So Dr. Thompson is an OBGYN with Central Phoenix OBGYN, and she is just incredibly passionate about helping women of all ages to make empowering life choices, and is going to tell us more about how to establish an environment where women and infants can thrive in their communities. So we're going to stop sharing here and have Dr. Thompson pull up her slides, and then we'll get going again. Thank you.
So I am pulling up my own slides, right?
Yes, please.
Awesome. Let's do that. Well, welcome to this session, and thanks to all of you for bearing with us through the technical difficulties. We're going to talk about social determinants of health for this session, and I'm going to get us started by talking about expanding our sort of conceptual framework beyond genetics and behavior toward creating conditions for health. And in the interest of disclosure, I just put up a few relationships there. I don't think they present a conflict for our discussion today. So let's start with a question. What factors determine who is healthy and who is not? If we were together in a room, you might say words like genetics and nutrition, environment, housing, health insurance, and those would all be correct. Over the last few decades, doctors and public health professionals and others interested in health of populations have put this question and tried to come up with some models that help us figure out what factors cause disease and what factors influence health. And they've come up with several models that I've listed for you here. Today, we're going to talk about the social determinants of health model, but there are others that you can research. We don't have time to go into them all today. I will tell you that all the other models have something in common. They are focused around choices, around individual choice and individual behavior. And this is sort of the framework that we hear a lot of politicians use, or a lot of lawmakers, or we see in the media where they talk about health behaviors and health choices. Now, those of us doing this work feel like social determinants of health is a more robust model because it goes beyond individual choice. And just to give you a little bit more about it here, it focuses on education access and quality, neighborhood and the built environment, healthcare access and quality, economic stability, and then social and community context. So some people will ask the question of, why do we need to talk about this? We're interested in health, so why address social determinants of health? Well, the goal is to create social, physical, and economic environments that promote good health for everyone. And what I want to tease out here is the underlying sort of premise of this goal. And that is that our behaviors and our choices have a context. So for example, exercise. Whether you exercise or not is more than just, did you get up this morning and put on your gym clothes? It depends on, is your neighborhood safe? Are there walking paths or parks? Do you have disposable income to afford a gym or a personal trainer? Even our genetics depends on the context. And if you were at Dr. Lynn's presentation earlier, she mentioned this a little bit, right? So let's say I have a genetic predisposition to breast cancer. Whether I express that gene or not depends on the nutrition, the foods I got to eat all my life, the chemicals that I might have been exposed to in my neighborhood, the pollution in the air that I breathe. So even our genetics has a context. These things don't exist in a vacuum. Let's dig into this a little bit more by talking about a case. And Sonia, who I'm going to talk about next, is a real person who I've taken care of, and this is her real story. So let's dive into that real quick. This is Sonia's story. When I met Sonia, she's a 40-year-old woman at 22 weeks of pregnancy. First visit, Sonia let me know that she was drinking every day and that she had been told in the past by her doctors that she had some liver damage. Now, Sonia's story was even more complex. Sonia was in love with a man who was incarcerated, and in order to get housing and food, she agreed to live with another man who is the father of the child she's pregnant with. When Sonia came to see me, she wanted a termination of pregnancy. So let's stop with Sonia's story there and ask ourselves the question, what factors are going to influence Sonia's health? So to contrast two models, I'll show you a framework using that sort of genetic behavior model and then the social determinants of health model. So if we're looking at genetics and behavior, if our framework is Sonia's health is about Sonia's genetics and her choices, then we're going to think about her age, her nutrition. She's pregnant, she has liver disease, she's using alcohol, and she wants an abortion. That's going to frame how we see her healthcare. But if we widen our view just a little to incorporate social determinants of health, our thought bubble is going to get much bigger. We're going to think about that relationship Sonia told us that she was in and raise red flags about Sonia's safety. Her housing is unstable. She's just living with someone who allowed her to stay there, and not someone who she's really in a relationship with or who really cares about her for the long term. Sonia gave us a complicated story about her situation, which makes us think about her mental health. Of course, in terms of her alcohol treatment comes to mind, and how available is that for anyone versus someone who's pregnant. So I just put this here to illustrate how much broader our concerns become for Sonia once we take social determinants of health into consideration. So let's hear a little bit more of her story. This is a lot of information on a slide, but basically it tells you two things. One, Sonia did not get the abortion that she wanted. We all are familiar with the state regulations, and I think it's more in the news these days, that put barriers in the way of women who are seeking abortion. And because of those, in part because of those, Sonia did not get the termination she was seeking. Also, Sonia missed several appointments, both for her routine prenatal care and the specialty care that she needed for her liver disease. When I saw Sonia again at 32 weeks of pregnancy, she admitted quite tearfully that she was still drinking to help her cope with stress, and she was in despair about the state of her life in general. Sonia said that once this baby was adopted, she was going to change her life. She had had enough of living the way she was living. And I just want to highlight here that although Sonia wanted a termination of pregnancy, once she didn't get one, she wanted this baby to have the best life possible. And she recognized that she was not in a position to give the baby the life she wanted it to have. So again, let's ask ourselves, what are the factors? What has changed in terms of our models? So let's look at our genetics behavior model. Now, if we're just looking again at behavior, at choices, we're going to talk to Sonia about her non-compliance. She wasn't coming to her appointment. She missed a whole lot of care. We're going to talk to her about, hey, Sonia, this alcohol you're drinking is going to affect your baby. We're going to try to influence Sonia by talking to her about her choices and her health conditions. Again, bigger bubble when we start looking at social determinants of health. We're going to think about transportation. Was that an issue for Sonia? We know Sonia doesn't have a lot of money. So what is her ability to get the social support she needs, the mental health care she needs, access the addiction services she needs? So the questions that we ask, the ways that we try to influence Sonia will differ depending on which one of these models. And I hope I'm convincing you that we do a better job of addressing what factors cause disease and what factors influence health when we look at social determinants of health. Yes, when we look at genetics behavior, those things are true, but they're incomplete. Let's go to the end of Sonia's story for today. At 33 weeks of pregnancy, Sonia arrived to the hospital in respiratory distress, and she was found to have a fetal demise at that time. The baby had already died. Shortly after arrival, Sonia suffered a cardiac arrest and could not be resuscitated. Now, I know that wasn't a happy ending, but it's a true ending. This is, in fact, Sonia's story. And Sonia is one of the women that caused us to be here today. She inspired us to be here. And her story is one that makes us realize that the need for change is critical. I hope that you will join me in my commitment to practice in a way that looks at the broader picture, that creates a framework where women like Sonia can still get the care that they need, that we address Sonia where she arrived to us and not where we thought she should arrive. Lots of times when we address only behavior and genetics, we're preaching to people about who they should be and not addressing who they actually are. But before I leave you today, I want to address two other things that are so important when we talk about social determinants. And they're often elephants in the room. So these are the social determinants that I talked about before, and I want to address two more. One is racism, and the other one is caste. And you probably are familiar with the one and not so much with the other, and I'll just briefly cover them both. So the importance of addressing racism is that we can talk about education and neighborhood and environment, but if we don't address racism, we're going to miss a critical piece of how these things manifest. So racism can result in inequitable legal policy and hiring practices, unequal resource distribution, that limits education, that limits access to housing, that limits employment and then economic stability. And so we have to address those things, but also the role that racism plays in shaping how they play out for different populations. And we see this when we look at disparities in health outcomes and in healthcare. And to tell you a little bit more about caste, I'm going to use a quote from Isabel Wilkerson's wonderful book by the same name, Caste. If you have not read that book, I highly suggest you pick it up. And she says, caste is the worn grooves of comforting routines, unthinking expectations, and patterns of a social order that have been in place for so long, it looks like the natural order of things. A caste system is an artificial construction, a fixed and embedded ranking of human values that sets the presumed supremacy of one group against the presumed inferiority of other groups. Caste is not hatred and it's not personal. Caste informs some of those implicit biases that we know make a difference in who gets healthcare and the quality of healthcare when people of different groups arrive with the same symptoms. These two factors, racism and caste, have to be addressed as we do this work on social determinants of health, because, and again, I will leave you with another quote from Isabel Wilkerson, you cannot heal what you have not diagnosed, and you cannot repair what you do not see. I thank you for your attention this afternoon, and I hope that Sonia's story has touched and inspired you. While Sonia is not with us physically, her life and legacy will continue to have influence through the decisions and the actions that we take after today. Thank you so much.
Thank you very much, Dr. Thompson. Let me just make sure that we can see. All right, so at this point, I am going to introduce Dr. Richards, who is going to come on and speak to us next about social or Indigenous determinants of health, and then we'll go to the question and answers for the entire session. So at this point, I'm going to introduce Dr. Richards. So she is an assistant scientist with the Johns Hopkins Center for American Indian Health. And Dr. Richards' research interests include exploring the role of Indigenous doulas in preventing maternal mortality and improving birth outcomes in American Indian communities. And she's going to tell us more about the Indigenous determinants of health to support Indigenous women and infants in Arizona. So thank you very much, Dr. Richards. Dr. Richards, I'll let you go ahead and share your screen when you're ready, and we are good to go.
Could you see me?
We can see you, but you're not sharing your screen. Could you share your screen again for us?
Yeah, let me try it one more time. Sorry. Is that good?
Perfect. Thank you.
Okay. Unfortunately, I can't see others. I'm not sure what happened. We just piloted this, so let me see. Give me just a second. I want to make sure I can see everybody. Okay, well, unfortunately, I'm not going to be able to see everyone, so I'll go ahead.
Yeah, Dr. Richards, you should be good. For some reason, the slides are just a little blurry for a second, so we'll give them a second to maybe re-upload. So now we can see your desktop. You try sharing your slides. We're pulling up your slides one more time, and we'll give them just a second to load. That's probably
Are they sharing?
So I basically see the photo of you and your daughter in the, okay. And now that's gone.
Okay, let me
try to, it did when I was speaking earlier, I couldn't see the video either, but I could see the slide. So that might be when you reach.
Okay, all right. I'll just go ahead and share without seeing everyone, which is not fun, but
I know, I apologize.
That's okay, that's okay. Okay, how about now?
Looks great.
Okay, I'll go ahead and get started. I know that we're already running behind. and we're pressed for time. So I just want to thank everyone for joining and bearing with us with all of the technical issues that we have. It's Benish A. Jennifer Richards, Yunisha, Ashihin Ishle, Nathlani Bashichin, Toatni, Edashache, Nathlani Edashanale. Tonanes Dizident Nasha. My name is Jennifer Richards. I'm Salt Clan and I'm Navajo and Taos Pueblo on my mother's side, and I'm Oglala Lakota on my father's side. And I just wanted to acknowledge that I am calling in from Kinflane, Flagstaff, which is traditional homelands of the Diné, Hopi, Apache, Yavapai, Hualapai, and other area tribes. As she mentioned, I'm an assistant scientist with the Johns Hopkins Center for American Indian Health. And today, just very briefly, I want to thank Dr. Thompson for an excellent presentation. My presentation is actually a bit of an extension on hers as well. So instead of social determinants of health, I'll be talking about Indigenous determinants of health and how they relate to maternal and infant health outcomes, and hopefully finish with talking about some community-driven, culturally driven solutions to addressing some of these disparities, and some key takeaways for providers in supporting the ongoing learning of Indigenous determinants of health. Okay, hopefully I went to the next slide. Do you see a map?
Yep, I do see a map. Looks great.
Okay, thank you, Clarke. It's really hard to not see what everyone else is seeing. Without going into a ton of detail, I just wanted to share this graphic. I really liked it. It was developed by the Urban Indian Health Institute and shows the population density of American Indian Alaska Native. Unfortunately, Alaska Native is not shown on here, but American Indian Alaska Native population density. We're at 3% of the total population in the United States, which is up from the last census, from 1 to 3%. This also includes the 229 tribal nations in Alaska. So I thank you to Clarke for going over some of this context. I'm not going to spend a ton of time here, but as we all know, infant mortality rate is one of the key gauges of community health. That being said, American Indian and Alaska Natives have almost twice the infant mortality rate as non-Hispanic whites, 2.7 times more likely than non-Hispanic white infants to die from accidental deaths before their first birthday, and 50% more likely to die from complications related to low birth weight. In 2019, Alaska Native American Indian mothers were almost 3 times as likely to receive late or no prenatal care as compared to other moms. And American Indian Alaska Native moms are 70% more likely to smoke during pregnancy. So just context, as I mentioned, 70% of Native people do report living in urban areas, and this was confirmed with the most recent census as well. I just wanted to point this out because even though we have the same overall health disparities, those living in urban areas, their disparities are often compounded by a lack of access to cultural teachings and extended kinship networks. So some of the same disparities, late or no prenatal care, a high infant mortality rate, and higher rates of SIDS. I just want to note that this does vary by region. So looking at American Indian Alaska Native mortality, Clarke went over a lot of this, but we have extremely high rates. If you look at the second major bullet, the Arizona maternal mortality rate is 70.8, so about 4 times that of non-Hispanic white women. It's a tremendous problem. The top 3 causes are hemorrhage, cardiomyopathy, and hypertensive disorders of pregnancy. One of the key takeaways of the report that the Arizona Department of Health came out with was that 89% of the pregnancy-related deaths are preventable, and possible preventive factors are listed here. When I share these slides with everyone, I will include all of my references. So if you have any questions about some of these details, I will include references. Dr. Thompson went over social determinants of health beautifully. What I wanted to talk about here and spend most of my time on is Indigenous determinants of health, which some of you may have not heard of. So this just says that similar to social determinants, Indigenous people have more nuanced determinants of health. So our health is very uniquely dependent and very uniquely impacted by cultural, historical, socio-political factors that some other racial ethnic groups might not have. And I really like this graphic. This is out of the First Nations Health Council in Canada, and it just shows that in addition to racism, which is what Dr. Thompson touched on, our health is impacted by colonization, connection to land, control of our natural resources, language, sovereignty, access to healthcare, historical trauma, So these are just a few of the Indigenous determinants of health that I'll talk about today. I do want to point out that colonization, more than anything, has impacted our health in a way that we cannot deny. Canada has written more about this, and I will link to some references there. So in talking about historical trauma and colonization, I think it's important to acknowledge the impact that federal assimilation policies have had on Native health. I'm not going to go into a ton of detail. I just wanted to highlight that there was different periods starting from when Columbus arrived to present day that involved land theft, it involved forced displacement, it involved our children being placed in boarding schools. And it involved also forced relocation and the federal relocation program. So this had a huge impact on maternal and infant health. It was breaking down our traditional parenting. It broke down our extended kinship and family networks. It was extremely damaging to social and emotional health for those that experienced it. It impacted traditional gender roles. We had a loss of ceremonies. Our ceremonies were criminalized for a long time. Disruption of traditional birthing practices. And these all really manifested as modern day disparities like substance abuse, mental health disorders, suicidal ideation. We talk about Native kids being in the foster system at a higher rate, cultural disconnect. So there's a lot of ways that federal assimilation policies have impacted our health and historical trauma. And often we don't hear about that. So I do like the Indigenous health framework, the Indigenous Determinants of Health framework, because it acknowledges this. One of the biggest factors that I wanted to touch on today is when we talk about distrust of the medical system, we cannot disregard the history of forced sterilization in Native communities. So, this is why it's so incredibly hard for Native women and Native people in general to trust Western medical models. Over a 6-year period that followed the passing of the Family Planning Services and Population Research Act of 1970, physicians and clinical providers sterilized about a quarter of Native women of childbearing age. And there's actually evidence to suggest that this number was actually much higher. So most procedures were performed under pressure or duress and without consent, without the women's knowledge. And these were subsidized for IHS and Medicaid patients. So it's also important to note that Black and Latino women were also targets of sterilization during this same period. So research has already shown that stressors take a toll on pregnant women's health and increase the risk of both maternal and infant mortality. So I just wanted everyone to really consider this context when we talk about distrust of the medical system. Which is also very much connected is experience with racism. So for Native people, racism has been associated with a wide range of adverse health outcomes, including anxiety, depression, suicide, psychological distress, PTSD, asthma, the list goes on. And it's also linked with increased alcohol, tobacco, and marijuana use. I use these examples because there's really a lack of attention in mainstream media to some of these experiences with racism that Native people experience. And I actually thought that the Serena Williams example was a great example of how this happens to women of color when, and I can link to it as well. But basically, she knew something was wrong immediately following the birth of her child, and her voice was completely disregarded. Someone who has such a strong voice as Serena Williams to be completely disregarded is mind-boggling, and it's actually a really good example of what Native women and women of color in general experience sometimes. I also wanted to share this article. When we think of racism, we don't really think about the impact on our children's health. And I think that's why racism and the mascot issue and the cutting of our children's hair and the attention to missing and murdered Indigenous women, why Native communities advocate so strongly to bring awareness to these issues, because of the link between our children's health, especially around self-esteem and suicidal ideation, and some of these experiences with racism. One of the articles I was reading, Parides, he says, he does really a call to action that it's not enough to be aware of this racism, but we have to be actively anti-racist as clinical care providers. So for me, that was one of the key takeaways. Another Indigenous determinant of health that I wanted to talk about is just the Indigenous birthing knowledge around pregnancy, childbirth, and postpartum. I work as a family spirit home visiting trainer, and it's really kind of funny when we do training with tribal nations and we talk about evidence-based practice and best practices and promising practices. the grandmas kind of giggle in the back because they said, we've been doing this since forever, since time immemorial, back to sleep. We've had our kids in cradle boards since the beginning of time. We've had ceremonies that acknowledge comprehensive health, breast is best. We've been practicing breastfeeding practices since time began, and also swaddling. A lot of tribes have traditional swaddling techniques. So I think that we already have a lot of these protective factors within our Indigenous culture and teachings. And so that's really important to acknowledge as a determinant of health. And we have so many practices around pregnancy and labor and delivery and early childhood that differ by tribe. For example, Navajo women, we're really careful in how we prepare for labor and delivery. We don't have baby showers. There's several natural laws that are inherently protective for both mom and dad while mom is pregnant. So there's also infant milestones that we should think about, like the first laugh, the first haircut, the hardening of the soft spot. So I was talking to one of my good friends who actually works as OBGYN in a clinic on a tribal nation. And she said, I was asking, how do you implement clinically, culturally safe care? And she was saying, well, I just listen, I approach it with cultural humility, and I acknowledge that I am very much the student in a lot of these ways. So she said, as part of prenatal care, I don't braid my hair, I don't wear laces, I don't tie anything. I make sure that I'm really asking the mom throughout prenatal care, like, are there cultural teachings I should know about? Do you plan on bearing the placenta? So she's very much aware of the mom. And I think as a result, that has really helped create a safe space for the mom to feel when she gets her care. I'm not going to go into this in a lot of detail, but I just wanted to note that there is a tremendous access to care issue in tribal communities, primarily rural, remote communities, but also for urban natives as well. We have Indian Health Services. We have a big IHS clinic in Phoenix, but is very much chronically underfunded. This is still true today, that the federal budget allocates twice as much per capita for healthcare to federal prisoners than it does to IHS consumers. So that is really telling. We also have Public Law 638. Sometimes people will hear about that. That means that the tribes have taken control of the way their money is spent at the local level. So we have tribal healthcare corporations that are very much tribally led. Gila River Healthcare, Tuba City Regional Healthcare, Winslow Healthcare, those are all examples of 638 corporations. But I just wanted to note that there still is an access to care issue. Connection to land is huge for Native moms and babies. Our health is very much tied to the land through ceremonies, medicine, connection to ancestors, creation stories. So I really like this picture. This is one of the, I believe it's the Changing Women Initiative gathering that was in Windrock a few years ago. I'll show this picture again because it's just a beautiful picture. This was doulas coming together and midwives coming together, but it was done in Navajo country. So taking this into consideration, it's extremely difficult for Native moms to deliver away from home. And that's very common. Oftentimes Native moms will get their prenatal care from midwives locally, but then they'll have to deliver, 2-3 hours away from their support networks, away from their land. So the bearing of the placenta and the umbilical cord, that becomes a little bit more challenging. So it's just really important for clinical care providers to be conscious of the stress and the grief that is associated with being displaced from traditional homelands and how that can contribute to pregnancy complications. Traditional food systems, we are hunters, gatherers, fishers, farmers, and we traditionally ate very, very healthy. So the shift to commodity or commodified food and more recently processed foods have greatly impacted our health. So think about obesity and diabetes. So as Native people, we're definitely on a healing process to reclaim our traditional food systems, and do this through various programs. So in terms of pregnancy and women's health, there are traditional medicines for pregnant women that help with various symptoms and conditions, for example, bone broth for postpartum, but just accessing traditional medicine during that time is really important. So this is another Indigenous determinant of health is social support systems. So families raise children. I know that the whole "it takes a village" has been coined and used a lot lately, but this is really how our people live since time immemorial is, there's no single word for mother. That's your mom, and that's also your aunties, your shemayeje. And then fathers, we have a fatherhood program, and we don't just have biological fathers. We have grandpas, we have uncles, we have stepfathers. the whole family is part of that support system, and then the extended family as well. So as Native people, and especially as Navajo people, our cultural identity is largely based on kinship. So having that extended, especially matrilineal network there to support moms as they give birth and to support children as they're being raised is really, really important and a major protective factor for health. Language, so the concept of health being tied to language isn't really discussed from a Western standpoint, but for Native people, they're very closely linked. Our languages were nearly wiped out because of colonization and boarding schools, so we're on a journey to revitalize our languages. From a birthing standpoint, there are tribes who have beliefs about language use during birth. Language is spoken to the child as soon as they're born, and the way language is even used during pregnancy. So no yelling, no harsh words. Those are naturally protected to keep the mom's stress down. The promotion of gentle words and song during pregnancy. So it's aimed at reducing anxiety and conflict and really promoting confidence during the perinatal period. So language is powerful and it's sacred and it's medicine. So with that, I just want to close with two potential solutions, community-based, culturally driven solutions. The first is Indigenous doulas. I'm sure there's many on here today, so they are fantastic. These are lay community birth workers from within our community who support primarily the mom, although there are different doulas now. There's postpartum doulas and there's doulas that actually work with the family. The great thing about Indigenous doulas, and I've cited two great resources here. One is a literature review and one is, I believe, various Canadian doula collectives were interviewed and they came up with themes based on those interviews. So one of them is that Indigenous doulas are responsive to community cultural needs. Another one is that doulas build connections with moms, which promote their clients' confidence and skills, and they advocate for them. So doulas have shared lived experiences, they have a wealth of cultural knowledge, they help to counter medical racism, which is what I briefly talked about earlier. They actually, in one of these studies, ended up being quite a big support for the father. They can provide trauma-informed support and support for high-risk pregnancies. So high-risk meaning advanced or very young maternal age, those having pre-existing conditions, and even substance-using moms working with harm reduction. Early childhood home visiting. This is the one I'm most familiar with is Family Spirit. So there's a lot of early childhood home visiting programs. Parents as Teachers is another one. Family Spirit is evidence-based and tailored for tribal communities. So this is working with pregnant moms until the babies are 3 years old, and it is composed of 63 lessons. It's home visiting, but it's really meeting them where they're at. So sometimes that might be meeting in a communal location. We aim to strengthen linkages with community partners, strengthen the referral process and include the family where appropriate. As far as the evidence base, there are some amazing findings. One of them being decreased maternal depression, decreased substance use among moms, increased parent self-efficacy, and reduced parental stress. So there's a lot of evidence out there for other early childhood home visiting programs, but I've also linked to some of the resources with Family Spirit. So with that, I don't want to go over my time. Key considerations are that the Indigenous determinants of health impact maternal and child health, and they should be considered in delivering culturally safe healthcare. So moving forward, I talked about two potential solutions, but also increased tribal participation in maternal mortality review committees and infant mortality review committees. I know the National Indian Health Board has a funding mechanism out there to support the MMRC effort. The continued need for American Indian, Alaska Native specific data, and then lastly, a call for anti-racism and a call for providers and those working with Native women to really show cultural humility and becoming culturally immersive and culturally focused so they can provide culturally present care. So with that, I'll go ahead and close out. Here's my email, and thank you for your attention.
Perfect. Thank you so much, Dr. Richards and Dr. Thompson, for you are both my heroes for changing the plan and doing this on the fly. So right now I've got a couple of questions for each of you. And then we're hoping to bring back Dr. Lynn to answer a question from the previous session too. So I'll go ahead and just start moderating through them. The first question was actually about the data slides that we presented. And so the question was that our severe maternal morbidity rates are really different here in Arizona versus the rest of the country. The question is, how can this be explained? And so The best way that we can explain it, and to be honest, our next step is to do some testing for statistical significance and causality and things like that. But the best way that we can explain the differences for Arizona is that our population for Indigenous communities and Indigenous women is higher in Arizona than a lot of other states in our country. And on the opposite end, our community of our population of Black or African American women and families is lower than other states, especially other states in the South and on the East Coast and things like that. So we think that those are some of the reasons why our data looks a little bit different. Again, we're wanting to do more of those deeper analyses to figure out the true reasons and causality and that kind of thing behind it. So as soon as we're able to do some of those, we'll make sure that everyone's has access to that data and those findings. Our next question is for Dr. Thompson. And the question is there an easily understandable way to present genomes to our client? So I've heard it described as a light switch that we turn on with our behaviors, but how would you describe genomes to your clients?
That's a very good question. I think that we can think of our chromosomes as sort of the information that determines who we are. So the information has options. So you could be tall or short, you have brown hair, brown eyes or blue eyes. And so it's just information. And the environment, the nutrition, the chemicals you're exposed to determine what is seen. Think of those as filters, which is something I think people would understand these days now that we have photo filters, right? So those social determinants are filters on that information. So what gets through is dependent on what filters and how many filters are in front of the information that is our genetics. I just made that up on the fly, but I think it's pretty good.
I loved it. Thank you. All right, so the next question is for Dr. Richards. So Dr. Richards, do you believe that forced sterilization in the 70s may be some of the reasons of why our moms don't go in for prenatal care?
I do. I think that, I mean, anecdotally, I'm a Native woman, and I know that women in my family are still recovering from incidents like this. And I do think that distress, it doesn't go away quickly. And I didn't even get into research abuses. So I do think that the overall distress of sometimes the medical healthcare model it does factor into attending. I do think there are other factors like access to care and, not having adequate transportation and being low income and, really having to decide if they can make it into prenatal care is important. But I do think that the history of mistrust and medical abuse does factor in for some women. I do want to point out that one of the comments said that sometimes they have to stay on the res for better healthcare, and that is very, very true. I'm from Tuba City, and our regional healthcare corporation is amazing. So I do think that is a really important and valid point. So thank you.
Perfect. Thank you so much. So I'm going to ask Dr. Lynn's question. So this is a question that came in during the last session, but for Dr. Lynn, the question was, if there is a woman who's only planning to have one child, would the fourth trimester continue indefinitely, or when would you consider an appropriate time for the trimester to end?
Good question. Can everybody hear me?
Yeah.
Okay. Good question. And I think that I would tell you that normally I would say, well, once that person is either in menopause but the problem is, I think that now with the limits of technology, if the patient is undergone desired sterilization, they can still get pregnant, or they are in menopause, they can seek in vitro fertilization for contraceptive for pregnancy. So really, I think technology has kind of opened things up to where women can actually be pregnant even after sort of what will be expected as kind of times where they would in previous years they would already be stopping. So I would say that it's really that fourth trimester just kind of really continues until either again the woman is in menopause, or truly even in those circumstances, if women are seeking care after that and pregnancy after that, then they're still in the fourth trimester.
Perfect. Thanks, Dr. Lynn. This next question is for Dr. Richards again. So Dr. Richards, what would be the best way to initiate a doula program on a reservation? Who could we contact for help? Any information or ideas you have about that might be helpful.
Yeah, there's some amazing doula collectives already out there. I attended some trainings with Sagidi, which is, I'm probably butchering the way it's said, but it's based out of Canada. And also Changing Woman Initiative might be able to provide additional information. I'm also fortunate to be able to attend some of the Diné Doula Collective events. So there are definitely, especially in Canada, there's a lot of doula collectives that you can look at their programs and how they started, and maybe start there, but also looking at other tribal nations and seeing how they started their doula collectives and what trainings that they went with, because I know there are different trainings. There's full spectrum, and then there's different types of doula training. So I think that would be a good place to start.
Perfect. Thank you. All right. This question, this is another one from the previous session, but I'm hoping that either Dr. Lynn or Dr. Thompson, you can help us answer this one. And I think it might have been more related to what Dr. Gilliam was talking about, but can you share any information that you have about what factor breastfeeding plays when it comes to gestational diabetes?
So I think that in terms of that question, I think that there's two parts. So certainly breastfeed for women who have had gestational diabetes, if they breastfeed, well, let me stop. So women who, the other sort of thing that I'm really passionate about in terms of pregnancy is that pregnancy really is like having a crystal ball and having a window of opportunity to look to see what your future health may be. So women who struggle with hypertension during pregnancy have a higher chance of hypertensive disorders outside of pregnancy. Women who have gestational diabetes during pregnancy have a higher chance of diabetes in the future. Women who, for instance, have something called cholestasis of pregnancy or gallbladder related have a higher chance of having gallbladder disease later on. So you see this idea that the pregnancy is sort of, we have certain genetic tendencies that we're bringing to pregnancy, and pregnancy is kind of augmenting that. Now, as that relates to breastfeeding, so in a woman, again, who has had gestational diabetes and therefore is at increased risk for diabetes in the future, breastfeeding reduces that risk, and also breastfeeding reduces the risk for the child in terms of obesity and other kind of long-term complications. So breastfeeding is tremendous, and we certainly support that in all the women we take care of.
I would add, I agree with everything Dr. Lynn said, and I would add that if we're thinking about social determinants of health, let's put breastfeeding in one of those determinants. We know that breastfeeding has tremendous health benefits for moms and for babies, both in the short term and the long term. But then when we look at our culture and we look at those sort of global factors, they don't really support breastfeeding, right? So who gets the breastfeed and who doesn't? We can almost map communities that have high rates of obesity, communities that have high rates of prediabetes and diabetes on breastfeeding, right? We could, I've never done that and I haven't seen that map, but I bet we could, because the same factors that impede health in a community, sadly, impede breastfeeding as well. So we know the health benefits of breastfeeding, and Laura, it would be tremendous if we could shift our framework into a country that was supportive of breastfeeding for all women, because the health benefits for both moms and babies in short and long term would be tremendous. But it's the same paradigm.
Thanks so much, Dr. Thompson. So I think this is going to be our last question, unless something else comes in at the last minute. I know we don't want to keep us over too long, but this one is directed towards Dr. Richards, and then if anyone else have thoughts to let us know. But Dr. Richards says, I think that traditional teachings about maternal and infant care in Native people is fascinating. It made me wonder, though, why then is infant mortality so high? Is it because of losing traditional teachings or no longer following these teachings, for example, in the area of safe sleep?
That's a good question. I think infant mortality rates vary widely by region. I used to work in the Northern Plains where it was very high, and I worked on South Dakota tribal prams. And I think there's a lot of different factors. It's not just the loss of cultural teachings, it's a combination of all of those social determinants of health and all of the Indigenous determinants of health that I think factor in, you know, even breastfeeding, low breastfeeding rates. I don't think it's just the loss of cultural teachings. I do think that, I mean, we know this with the research that cultural connectedness and a lot of different cultural teachings are buffers against high-risk behaviors. So I do think that also smoking during pregnancy is something that was also factored in. So there's a lot of different reasons. But one thing I want to say about safe sleep is it's really interesting how you message that with tribal nations. There are some tribes who have teachings around sleeping with their child because for spiritual reasons, you know, they sleep with them to protect them from, you know, from the spirits. And there's a really cultural, there's a cultural teaching around that you have to be respectful of. So a lot of tribal nations, you probably won't see cribs, and, you know, a lot of people will sleep with their baby. I know I did. So with early childhood home visiting that is culturally responsive, we try to advocate separate but proximate. And we also use harm reduction. So Healthy Native Babies targets infant mortality through the Safe Sleep campaign. So with that, they kind of go into tribal nations, acknowledge tribal teachings around SIDS and suffocation, and try to do harm reduction techniques. One thing I also want to note is that I did attend a few infant mortality reviews where they were talking about the misclassification of SIDS and how that might be a factor in the rate being so high in some areas, misclassifying suffocation especially. So there are nuances around the high infant mortality rate, but those are just some considerations.
And Clarke, if I could add one thing, this question made me think about, and Dr. Richardson's presentation brought this out so nicely, is that we, and I think this is an American thing, we're so used to always having these reference, right? So we will say, you know, Black women have a rate of preterm birth that's 3 times higher than whites, or a rate of maternal mortality that's 3 times higher than whites. And what that can mask sometimes is that these communities that often are the worst or have the most morbidity or most mortality have lessons to teach all of us. So we have to get out of the habit of looking for the solutions to problems in only one place. So Dr. Richards talked beautifully about, you know, there are many Native traditions that we have ignored or negated or destroyed, but that had we been using them, we would have all be benefiting from the wisdom of that teaching. And same for Black communities, same for Latino, same for Asian. And so we have to remember that every community can be the solution to problems, even if it's their problem. And so we have to appreciate, and that's not to say that Black communities have it all right or Native communities have it all right, but we have to appreciate that there's wisdom in every community, and Western medicine is not the be all and end all for wisdom. We can find wisdom in Native communities and Black communities. We can look at how people are living right now. The same groups that have high rates of infant mortality, the same groups that have high rates of diabetes. And we can look at those communities and find solutions to existing problems. So I just wanted to pull that out of that question.
Perfect. Thank you. Thank you. Well, I think those were the questions. Those were all the questions that had come in for this session. So thank you again to the 3 of you for rolling with us and making it work. We really appreciate you. And if any other questions come in, we'll make sure to loop back with the person who answered them and get them a written response. So at this point, I'm going to ask Dave if he can reshare the slides, and we're going to bring Martine back on to close us out for today. But again, thank you so much for all your patience with the technical issues. We hope they're gone by tomorrow. So I'll turn it to Martine.